All right, the anaphylactic transfusion reaction is actually something that, if you've been watching the video series so far, we've actually talked about this already. And so, I'll go through this a little bit more quickly, but we did hit on this when we talked about the immunodeficiency syndromes. But it fits in really nicely here, and it's something that you sometimes have to tease out from the other transfusion reactions. And so let's just go through it one more time because this is particularly high yield. The concept here is again, we have a recipient that's getting blood from a donor, okay? And in this situation, this blood here, let's just say that this blood here is the donor blood, okay? So again, this is gonna be the donor, okay? So the donor is giving some blood, and in that blood sample, potentially, there might be some antibodies. So again, we have our donor here, and this donor is donating some type of blood, right? It could be whole blood, potentially red blood cells that might have antibodies, could be plasma, whatever it is. But we're donating some blood. In a board question, they're probably not gonna go into all the specifics. They're just gonna say this patient was transfused with some blood. But the concept here is that the donor, right, is gonna give this blood, and most patients will probably have IgA antibodies, okay? And so this is gonna be the IgA antibody. Now, when that blood is donated, normally this wouldn't be a problem, right? Because most patients have IgA antibodies. However, what we're talking about specifically here is a patient that does not have IgA antibodies, okay? So this is a patient that has IgA deficiency. This is the recipient, has IgA deficiency. What does that mean? That means that they don't have IgA antibodies. Because they don't have IgA antibodies, their basophils and their mast cells, right? You can see them here, right? Here's a mast cell. Their basophils and their mast cells are going to have anti-IgA, IgE antibodies bound to the surface of those mast cells. If I give this patient IgA antibodies in one way or another, these IgA antibodies can then bind at the IgA Fc portion to the Fab portion of the IgE antibodies. When these cross-link, these mast cells will degranulate, okay, and release all of this histamine and substances like we talked about, like tryptase, into the serum. This can cause an anaphylactic reaction and will typically be worse on repeated exposures like any other type 1 hypersensitivity, okay? And so this is something that we've touched on when we talked about type 1 hypersensitivities, but we've really talked about this in great detail in the immunodeficiency videos. And it's the same concept that we talked about before. We're just integrating that concept into the transfusion reactions here. So again, the classic cause is going to be a recipient that has IgA deficiency, right? They don't have IgA antibodies. Instead, they have anti-IgA antibodies. In other words, they have antibodies that will mark IgA for destruction. Or in this situation, they've already class switched and they have IgE on the surface of their mast cells and their basophils, and so they're ready to degranulate. These are preformed. As soon as you give this donation of blood with IgA, it's going to bind. You're going to get instant degranulation. So again, this is going to be more immediate, right? We already said, what's type 1 hypersensitivity? What kind of hypersensitivity? It's immediate, right? So again, all of this stuff is interconnected. It's not separate pathologies. So if you've been following the video series so far, a lot of what we're discussing here is just review at this point, right? So IgE-mediated degranulation, we already said, with histamine. Okay, and again, it's the recipient that has the anti-IgA, IgE antibodies on the surface of mast cells and basophils, and it's the donor, IgA, in the blood sample. So these patients, if you think about it, how does a type 1 hypersensitivity present? Hypotension, tachycardia, urticaria is very classic, wheezing, all the things we talked about in the type 1 hypersensitivity video. Now, if I do a Coombs test, what's going to happen? Well, I'm not marking red blood cells for destruction per se, especially if I'm using anti-A antibodies or anti-B antibodies against the red blood cell surface antigens, right? That's going to be negative. I'm not getting red blood cells being destroyed here. I'm getting histamine release. I'm getting an anaphylactic reaction from this histaminergic response, from the degranulation. So again, red blood cells aren't being destroyed. You know that red blood cells aren't being destroyed, so you shouldn't have elevations in bilirubin and LDH. You shouldn't have decreases in haptoglobin. The classic hemolysis lab should not be present for the reasons we just mentioned. You just have to kind of think about it. You have to think about what this means, and is that actually happening? It's not happening here, right? We're just getting degranulation. We're getting a type 1 hypersensitivity reaction. And so what do? Again, every situation, if they're symptomatic during the transfusion, you just stop it. Now, if it's an anaphylactic reaction, you just have to take that one step further. What did we say? For type 1 hypersensitivity, what was the treatment? Well, an immediate treatment would be epinephrine, right? If the patient is going into anaphylactic shock, we would do epinephrine as an initial treatment. And we'll talk more about that for step 2, but just something you should kind of have an idea with. Management isn't, a huge thing on step 1, but it's something that you should be familiar with just at a high level, okay? Because they can ask you about a drug that was given and then ask you what the mechanism of that drug was, okay? That's still fair game claim. And so you have to know that. Okay. And so respiratory support, again, if the patient needs it. And then on future occurrences, this is the big thing. You want to make sure that these patients are given IgA deficient blood products. You want to make sure if they need blood products, there is no IgA in those blood products, because that is precisely what caused the problem to begin with.